Hello, everybody. Whoa, that was loud. I am so glad you're all here today. Welcome to McFarland Senior Outreach. My name is Katie Gleddy-Syan. I am the director here, and I'm so glad that we have such a good turnout for our presentation today. So this is fabulous. A few things before we get started. I just want to make sure you know that the drinking fountain is out in the hall here, as well as the women's and men's restroom is right on the hall if you need that. Now would be a great time to take a moment and take out your cell phone and make sure it's silenced or turned off or on airplane mode or whatever. I'll let you know that we are recording and live streaming today. So what we'll do is we'll hold questions to the end. And then if you have a question, I have a microphone that I'll bring around so that everyone can hear you really well. Okay? I do want to take a moment to thank two McFarland businesses. If you didn't get a chance to get some samples up at the front here, a new med spa, which is here in McFarland. They donated samples of really nice sunscreen for everyone in those little baggies. And we also have donations of SPF lip balm from Lakeview Modern Dentistry in McFarland. So if you didn't get one of those, grab one on your way out. So today we are proud to welcome Dr. Apple Bodemer, who's here through the Badger Talks program, which is a speakers bureau for the UW-Madison campus. The University of Wisconsin-Madison Badger Talks program reflects the tradition of the Wisconsin idea to extend the resources of the university to citizens of the state. The program connects over 550 faculty and staff from hundreds of different disciplines with communities throughout the state to spark conversations on important topics, engage residents on critical issues, and share the latest UW research. So I'm pleased to introduce Dr. Apple Bodemer, who will be presenting on skin health for older adults. Dr. Bodemer is a professor of dermatology and is board certified in dermatology, integrative medicine, and lifestyle medicine. She serves as a core faculty for the Integrative Dermatology Certificate Program, as well as integrative dermatology as well as other educational programs through Learn Skin. She has authored chapters on integrative dermatology in key textbooks and written curriculum for the University of Arizona Integrative Medicine Program, as well as for the National Veterans Association Whole Health Initiative. Dr. Bodemer is passionate about community education and outreach and has worked with several media platforms as well as organizations including the Plantrition Project, the Food Revolution Network, and Mind Body Green. Please join me in welcoming Dr. Apple Bodemer.
Thank you so much. It's really nice to see so many faces out there. We've got a great turnout. I guess this is a popular topic, and I often get that. Everybody sees their skin, and a lot of my patients are in kind of the similar age group as you all are, as things start to change in our 40s, 50s, 60s, and beyond, and skin cancer becomes a concern. So I'm hoping that today we can talk about some of the common things that show up, to understand why these things happen to our skin, to understand some of the common things that show up, and to go over some really good practices for skin care techniques that'll minimize your risks for these conditions. So to start with, what happens over time? I think all of us in this room have seen a shift from when we were in our 20s, 30s, 40s, and then we get into the 50s and 60s, and things definitely change, and they start changing faster as we get older for many of us. The skin gets thinner. There is decreased levels of collagen and elastin. And collagen and elastin are two structural proteins in the body that help plump the skin up. They act as a scaffolding for our immune cells to move around to where they need to be. And so we have decreased levels of them. And also over time, they get glycated. And what glycation means is that sugars attach to these proteins and cause them to not function quite as well. They cause them to get sticky and clumped together. So instead of having a nice mesh network of collagen, it's kind of more haphazard, and that can lead to some of the puckers and wrinkles and just textural changes we see in the skin. Our blood vessels also get more fragile. They break a little bit easier. We have more problems with bleeding and bruising especially. The skin dries out. We have decreased oil production as our oil glands just kind of slow down. Part of that's time, and part of that's shifts in hormones. And we also get decreases or disruption in the skin barrier. A 13-year-old skin is really nice and tight, and we've got skin is kind of like a brick and mortar, where there's not a lot of ability for things to get out, not a lot of ability for things to get in. But as we get older, something called the natural moisturizing factor starts to decrease, and that natural moisturizing factor is a collection of compounds that help it kind of act as the mortar between the cells, help keep the cells plump. It helps keep the tight kind of connections between the cells so that we don't lose as much water and that irritants don't have an easy time getting in. And I'll show you a nice little cartoon of this in a couple of slides. Then we also have decrease in the subcutaneous fat. And I think we all have experienced, especially after the age of 35, 40, that we start to get fat in places we don't want it and we lose it in the places we want it, like our cheeks, under the eyes, the backs of our hands. And so this is a little cartoon that kind of shows the difference between young skin and more mature skin, where you can see at the very bottom that yellow, that's our subcutaneous fat. That starts to kind of break apart, and even the fat is not quite so plump and robust. The septa in the fat, or the tissue that kind of holds the fat together, starts to break down. The blood vessels get thinner. We have just alterations in that little kind of that pink dense area in the middle between the two collections of blue and red blood vessels. You can see that just starts to get more irregular. And the surface gets thinner, and we start to see these wrinkles, color changes, thinning, what we call atrophy, and also this flattening of the connections between the skin and the subcutaneous tissues, or the tissues that are underneath that top layer of the skin. This is a scanning electron microscopy picture of elastin, and what happens, kind of a close-up picture and then a further away picture of when they're glycated. And so this is one of the reasons why we think about blood sugar, right? Nobody wants diabetes. A lot of people have prediabetes or diabetes, and especially as we get older, our ability to manage blood sugar kind of drops off. And this is one of the things that having high blood sugar does to the skin. So it's not good for a lot of other parts of our body, but another reason why we should think about what we eat and how what we eat might be impacting our blood sugar, because it's not just the skin that this is happening to, this is happening all over the body, this glycation issue. But this is what it's doing in the skin. If you can imagine, again, like I said, that nice kind of network of structures where things can move around on. When those nice straight lines become curvy and twisted and wavy, it's hard for the immune cells to kind of glob on, and they actually use this structure to navigate to get to where they want to be. And so that's one of the things that happens. It makes it harder for our immune cells to function in the skin the way that we'd want to, which puts us at risk for different types of infections. When we think about aging, about 80 to 90% of what we think of aging is actually photoaging. And that means that the UV radiation, aka sunlight, can penetrate the skin and cause DNA damage. And this happens over time. It starts when we're young and just kind of keeps going. And it's worse when we get sunburns, which is why a lot of people in my field don't go in the sun, don't get sunburns. I am one of the dermatologists thinks some sun is healthy for us, but we just have to be careful with how we're getting the sun, and we also have to take into account what our risk factors are. So the amount of pigment that we start with, like I don't have very much pigment in my skin at all. I have no business laying out on a beach on spring break in Florida, which is what I did as a teenager. I had no business doing that, but I did it, and I had multiple blistering sunburns and sun poisoning and all kinds of bad things, which definitely sets me up for not some great things as I continue to get older. But then also the amount of sun exposure we have, trying to limit it, and we'll talk a little bit about sun exposure and skin cancer risks in a bit. But the UV radiation can actually activate melanocytes, and melanocytes are the pigment-producing cells in the skin. So we all have melanocytes, and there are a couple of different kinds of melanin that those melanocytes make. And when they're behaving well, they're making enough melanin and the right kind of melanin that whatever we're genetically predisposed to have. But sun exposure can cause them to get revved up, and that's how we get lots of little blotchies, freckles. That's actually activation of those melanocytes causing freckling, and then sunspots and other kinds of pigment changes. We also get the texture changes because of the decreased collagen and elastin. That UV radiation will actually break down the collagen and elastin, and then that also increases our risk for skin cancer. Intrinsic aging is the aging that would happen if you lived in a basement and never saw the sun in your life, which would be a miserable existence, and I don't think any of us would want to subject anyone to that. We do get fat atrophy, and that just happens over time. And as I mentioned, under the eyes, in the cheek area, usually young folks have nice plump cheeks, and as we get older, that kind of gets more narrow. The back of the hand is a really delicate area, and you often can kind of get a sense of somebody's age by the back of their hand, even somebody who's done a lot of cosmetic surgery and those kinds of things, because we often forget to take care of the back of our hand. We put sunscreen on and then we're washing our hands so it wears off. And so that's kind of a place to just pay attention to, because it's also skin cancer on the back of the hand can be very difficult to remove because there's not a lot of fat there and there's a lot of big blood vessels that run through that area. The decreased melanin, so we'll get pale areas, just the intrinsic aging, the melanocytes get tired too, and they stop producing pigment, and it's uneven because the sun exposure is driving them to produce pigment, and then their just natural aging process is kind of driving them to not produce pigment, so we end up with blotchy discoloration. We will lose collagen and elastin over time anyway. That happens both with UV radiation exposure and just on its own. We have decreased skin moisturization. I mentioned that decreased skin, the skin moisturizing factor. The other thing that can happen is a lot of folks end up on cholesterol lowering medication. And cholesterol is a really important molecule in the skin. In fact, it's one of the major lipids or fats that helps connect the skin cells together. And so that, if you need your cholesterol lowering medication, you should definitely stay on it, but it just means it's going to be harder for you to maintain well-hydrated skin. And so it just means that if you're on those kinds of medication, just watch for, is your skin getting more dry? You might need to add a little extra moisturizer, and we'll talk a little bit more about how to do that at the later part of this talk. And then hormone alterations. That's going to happen no matter if we see the sun or not. And that can cause increased blood vessels and dyspigmentation. So that's why we get broken blood vessels, especially folks who are more fair. The blood vessels get closer to the skin and we tend to see them a little bit more. So that kind of is what's happening, but we'll talk specifically about common conditions that we see in older skin. And this is the list that we're going to cover today. So dry skin. One of the most common causes for itching is dry skin. So a lot of times I'll tell patients that come to see me, if you start itching in the winter, don't come see me right away. Start using a thick moisturizer first, because that'll take care of most of it. Not all of it, and then if you're still having problems, there might be something going on that you need help with. But that's the first thing to do. If you start getting itchy, think about, am I using a nice thick moisturizer or ointment or oil? Bruising is a common thing. People get really concerned about bruising, and we'll talk specifically about that. The blotchy discoloration that I've been mentioning all along. Intertrigo, which is irritation of the skin folds. Under the breast area, in the groin area, and under the arms are where we see it the most. But we can actually get a similar thing in the creases as we get more wrinkles, and especially if people are drooling at night, or CPAP machines can dry things out, and they can cause some problems in the corners of the mouth too. Shingles, zoster is the other name for that. That's the medical term for it, but that's something to be on the lookout for. And then fungal infections. We're going to cover toenails and feet. People can get fungal infections anywhere on the body, but toenails and feet are the most common places, and we'll talk about that. And then skin cancer. So jumping in with dry skin. As I mentioned, it's the most common cause for itchy and irritated skin. That natural moisturizing factor that holds the skin barrier together prevents water from getting out and evaporating, and then it also prevents things from getting in. So irritants, fragrance is a big thing that we see people have trouble with. That term fragrance, that might be on your lotion or your shampoo. There's several hundred of different products that can be labeled under fragrance, and it's very unregulated. So if you have sensitive skin and you tend to react to things, one of the first things that you can do is avoid products that have fragrance in them. Unscented doesn't mean it's fragrance free. So that's a really important thing to be aware of too, because the marketers know how to get us, right? We think unscented, that should mean fragrance free and we can go about it, but they'll use fragrance to mask other smells. And so they'll say it's unscented, but that doesn't mean fragrance free. So just be kind of on the lookout for that. The decreased oil production, decreased skin thickness, so it makes it easier for us to lose moisture from that thinner skin. And then swelling or edema, which becomes more common, especially in our lower legs, that causes those skin cells to kind of separate. And that puts us at risk for having water evaporate out and for irritants to get in. And so that's something to watch for. I'm a big fan of compression stockings or socks, and a lot of people don't like them, But if you start with a low compression and slowly work your way up to a more firm compression, I promise you that you'll probably find that you feel better. I don't have problems with swelling yet. I'm sure that's going to come for me. But when I'm on my feet all day long at work, or if I'm sitting in the car driving to my mom's house, which is an hour and a half away, or if I'm on a 4-hour plane flight, I always wear my compression stockings. And I feel so much more energized when I get out of the car. We kind of don't even pay attention to how much pooling happens, especially even in young people. We are kind of more resilient, and as we get older, our blood vessels are a little less resilient. But I'm putting in a plug to find some compression socks that you like and try to start wearing them. It's hard in the summer, but especially in the winter. That goes a long way to help prevent kind of bad stuff from happening with the lower legs. So how do we fix it? Thick creams, ointments, or oils, especially after bathing while the skin is still slightly damp. So when you get out of the bath or shower, you want to pat yourself dry. Don't scrub yourself dry. We want a little bit of moisture still on the skin, and then you lock that in with something thick and heavy. So the goal of moisturizing is to prevent and correct dry skin, to maintain a healthy skin barrier, and to create an optimal environment for a healthy skin microbiome. So this preventing aphasia, it minimizes access of irritants and microbes, so fungus and bacteria, to get to the deeper structures and then prevent itching. And the cartoon shows you a good, healthy skin barrier on the left, and then when we get disruption or dysfunction of the skin barrier, how those irritants can get in and the water gets out. So the term moisturizer is really a misnomer. We rarely actually are adding moisture to the skin. Most of what we're doing is preventing evaporation. And most of the moisture in our skin comes from our circulation. As we get older, we start to have problems with prostates and bladders and leakage, and people tend to not drink enough water as we get older. And so dehydration is a big problem for older folks. And it also impacts your skin. So it's something that's worth talking to your primary care doctor about trying to figure out ways to maintain your oral hydration, because that will impact your skin. It improves microcirculation. It decreases dryness and roughness, and we do see a slight increase in elasticity. Even though it's not creating actual elastin in the skin, it does make your skin a little bit more resilient. And a lot of people love lotions. That's mostly what people come in telling me, like, oh, I put a lotion on every day. And then I have to sigh a little bit and say, okay, we want to switch that thought process. So there's nothing wrong with lotions as long as we know what they are and what they do. They are a Band-Aid. They help protect the skin when we're out and about and can't have something thick on. But there's a high water content in lotions, as you can see. I love this picture because it really kind of shows the difference between water and Vaseline, which is pure fat and grease, and kind of in between. So the lotions, actually, because of their high water content, they actually promote evaporation from the skin. So depending on the lotion, some are better than others, but the thicker the lotion, the more cream-like it is, the better it is going to be at minimizing some of that evaporation. And so that's why your dermatologist, if you see one, is always going to say look for a thick, heavy cream or an ointment. I'm really a big fan of the food-grade oils or the plant-based oils, and I'll have a little list in a couple slides, because there's no preservatives in them. And I do see a lot of people with chemical sensitivities, and I think they can be greasy and they can be tricky for some people to use, but that's exclusively what I use on my skin, especially in the winter. I really like avocado oil or coconut oil. Those are nice thick oils that I can't tolerate as well in the summertime, but in the winter they work really nicely. I have had people complain that they feel really slippery. So what I recommend is people get an oil that they like and then have a pair of pajamas that they don't care about getting greasy and put those on after you put your oil on, or just stay wrapped in your towel for a little while. It will soak in eventually. And you do want to be careful because those heavier oils can block pores, and so if you're prone to acne, or if you have kind of a greasy rosacea, and if you have that, you would know, then you might want to just be careful about the type of oil that you're using. But I like them because there's no preservatives. They are unlikely to cause allergic reactions. If you're allergic to coconut, then coconut oil is not for you, but almond oil might be unless you're allergic to almonds. And then you know what it is that you're reacting to. They're easy to find. They're very affordable. You can find them in your grocery store. They're also soothing, and many of them have antioxidant and anti-inflammatory properties as well. So this is just a list, and I'll give you a minute if anybody wants to take a picture of that. And I think these slides are available, will be available, right?
We can make these available on
Yeah.
the website.
Yeah. And so this kind of breaks them down between light, medium, and heavy. And I've got the coconut, avocado, shea butter, olive oil is a good one. If you are going to be using them on your skin, you'll want to kind of pay attention to the same parameters that you would for cooking. If it smells rancid, don't put it on your skin. And because they can go bad, and especially if they're kept in a warm bathroom and you've got a huge bottle that's been sitting there for months at a time. Shea butter and coconut oil don't go rancid very easily, but olive oil does. And so, I generally recommend keeping some, maybe if you cook with it, take a little bit out for your skincare and keep it in your bathroom. Or if it's one of the other lighter oils that you might not use for cooking, keep your bottle in the freezer and then take enough out for a month or so. Because once they go rancid, they become pro-inflammatory, whether we're eating them or putting them on our skin. So that's an important thing to kind of pay attention to the oils that we use, both for skincare and for cooking. Moving on to the easy bruising. We call it solar purpura. The other name that I learned 20 plus years ago in my residency was senile purpura, but nobody likes that. And so the blood vessels, they become more fragile. They break more easily because of the thinning of the skin. The lining of the blood vessels also gets thinner over time. And then we have that decreased subcutaneous fat, so those blood vessels are less protected. Also, many people end up on blood thinners, or if you're not on a blood thinner, a baby aspirin a day. And that's enough to cause a little bit more tendency towards bruising. Health conditions like diabetes, liver, or kidney disease can also put you at risk for bruising. There's not much that can be done about it. Once we have that issue starting, the best that we can do is to slow it down and prevent it from getting worse. And the number one thing that you can do is UV protection. I'm a big fan of the protective clothing, and I really love these sleeves. This is a brand that, and we can talk about, there are several different brands out there, but I like the ones that have a hand covering. So the one that I have highlighted here doesn't have fingers, but it has a part that comes up over the hand and there's a hole for your thumb, but you can roll it back if you don't want your hands covered. But if you do want your hands covered, which I would suggest most of us should be covering our hands, especially when driving, because that glass will block UVB radiation that prevents burns, but it doesn't block the UVA radiation from coming through. And that UVA actually penetrates deeper into the skin, and it causes more problems with breakdown of collagen and elastin. And one of the ways that I was taught to think about it is UVB causes burning, UVA causes aging. And that's not totally true. They both cause both. But when we think about window glass, especially driving, especially the delicate hands, that's something that you want to protect, even in the winter. Being cautious about bumping, so these sleeves can, if you're wearing them outside, or long sleeves, that'll also help protect your skin. And paying attention, a lot of people say, I just look at a corner of a door and I bruise. It doesn't take very much, especially once this kind of has gone on for a while. Arnica cream can help with bruising. That's something that you can find over the counter. There are a number of different brands that have arnica in them. You just need to be careful not to put it on broken skin. So if you've got a cut and you're bleeding, the arnica that doesn't go there. But if it's bruising, then the arnica can be helpful. It doesn't erase them magically, but it can help them go away a little bit more quickly. And then oral vitamin C, about 500 milligrams twice a day, does seem to be helpful for some people. And what I tell my patients is it might not be enough. It might not be enough to be clinically evident. So you might not notice a difference clinically. And if it's not, then don't bother taking it, but it might help. And so it's one of these things that I can't say, oh, we can stop this bruising by having you take a little extra vitamin C. But vitamin C is water soluble. It's pretty harmless. It's something we can get easily from fruits and vegetables. So if we're promoting, if we're kind of filling our diet with lots of fruits and vegetables, if we can do that, then that helps too. Blotchy pigmentation. So this is UV radiation and intrinsic aging lead to activation of pigment-producing cells, so the increased pigment. Intrinsic aging leads to deactivation of pigment-producing cells, so less pigment, so we get this blotchiness. And then I wanted to comment about a certain type of skin growth called the seborrheic keratosis. These often are waxy and raised and can look very disturbing because they can be white, pink, yellow, brown, black, but they have a very warty look to them when they're raised. However, many people get flat seborrheic keratoses, and these can show up on the face. And so people will come to me saying like, oh, what do I do about all of this discoloration? Isn't there a cream I can use? For the flat seborrheic keratoses, they aren't even treated with some of the intense pulse light cosmetic procedures. So it's just something to be aware of. So what can you do about the blotchy dyspigmentation? Sun protection is the number one thing. Try to kind of prevent you from getting more damage over time. And what some people will say to me is, well, if there's a lag time between when I have the sun exposure and when I see the problems with my skin, I'm 80 years old. What do I care? Any sun exposure I get now, I'm not going to live another 40 years. But the more sun exposure we get, the faster those DNA mutations accumulate, and the faster those melanocytes start to misbehave. So that's one thing. There's a group of topicals called the retinoids that can be helpful. Retinol is widely available in a lot of anti-aging creams. They can be a little bit irritating. They are not super strong. So if you're wanting to see a big difference, you'd want to use something which adapalene is over the counter, or tretinoin, which is prescription. They can cause irritation to the skin, so it's something you might want to talk with your primary doctor or your dermatologist about to make sure that you're getting the right concentration for you. But this is one of the most powerful things that you can use from a topical standpoint. The prescriptions are not often covered by insurance when they're used for kind of anti-aging things, but the cost, depending on, some people are spending a lot of money on over-the-counter creams for anti-aging, and so it just depends on what your budget is. I think it ends up being about $60 or $70 for a 3-month supply if you're paying out of pocket for one of the tretinoin. And I think the adapalene, it's about $30 for a tube that should last probably 2 to 4 months. But it's something that you'd want to get clear instructions from your doctor about if you're going to do that. And then cosmetic procedures like chemical peels or light treatments. I wanted to comment about the seborrheic keratoses because these are so common. They don't turn to cancer. So they're benign growths that do not turn to cancer. They have a waxy, sometimes warty looking surface. They're often raised, but as I said, they could be flat. They often can be many different shades of colors. And what I tell people is it's really important to look at your skin once a month as best you can. You don't have to have perfect vision. You don't have to get up close and personal and memorize every single spot on your body, because you're going to be getting more. But being comfortable with the kinds of spots your body makes and making sure that there's not something that's kind of really misbehaving. We'll talk about that when we get to the skin cancer section. It's a really important thing to be doing, because even if you're seeing somebody like me once a year or even every 6 months, things can pop up, and they can pop up quickly. So it's really important to just be comfortable with what's going on with your skin. And all it is a hand mirror and a wall mirror to kind of just peek at your back. Like I said, it does not have to be up close and personal at all. And when you're doing that, you want your brain in a relaxed state. It's your time to just look at your skin, not to memorize every spot and triangulate them and memorize the shade and the exact size. It's to be like, that's my back, that's my arm. This is what it normally looks like. Because if you're doing that regularly over months and months and getting that practice, you'll be able to pick up on something that's new or changing, and you'll be able to know what's important to bring to your either primary care provider or your dermatologist's attention. So intertrigo, and this is a nasty condition. It's inflammation of areas where the skin touches the skin, under the breasts, in the groin, underarms. Moisture plays a big role, and so incontinence, either from prostate issues or just from weakening of the pelvic floor muscles, especially in the groin, can really cause a lot of painful irritation. And then once the skin starts to break down, guess who likes to show up? Yeast and bacteria. And so it doesn't always mean that you have a yeast or bacterial infection if you've got the irritation. But if you see pustules or little white bumps, especially around the edges, that's a telltale sign that yeast might be involved. And if there's a lot of scaling and if it's very, very itchy, then it could be in that fungal infection category. So what can you do? The most important thing is to keep those areas dry. Sometimes people will take a hair dryer and dry those key areas out after bathing to just make sure that they're really well dried before you get dressed. Absorbent pads can be really helpful, and even something like a maxi pad, kind of in the groin folds or under the breast, or gauze. They have absorbent material that you can buy now that fit into our undergarments that can be helpful. Zinc oxide is one of my favorite things, and it sort of is part of the cycle of life, right? It's diaper paste. Zinc oxide, and I generally recommend 20 to 40%. A lot of times I recommend 40% because that's going to cause the most dryness. And I have my patients, we keep it at home. My daughter's in the back here and she can attest to, we have Bordeaux's butt paste as our one of our favorites, but there's Desitin, there's all kinds of other brands out there, and as long as it's the 20 to 40% zinc oxide paste, so some of her friends are kind of confused about why we keep that in the cabinet, but it's really good for poison ivy, for blisters, for bug bites that just get really blistered up. Anything where the skin is kind of wet and juicy, the zinc oxide can really be helpful for. Wearing loose clothing and then washing the areas frequently and making sure that they're dry. Moving on to shingles. So this is caused by a virus called the varicella zoster virus. This virus causes chicken pox in younger folks, and you all are old enough, and I'm old enough. I had chicken pox when I was young. My kids don't get chicken pox. They don't get them anymore because they're vaccinated for it. And as I think 50 is when we become eligible for the chicken pox vaccine, and or the varicella vaccine. They call it the zoster vaccine when we're older. And that's an important vaccine to get. I know there's a lot of vaccines out there and it can be confusing, but this is one that zoster can be really, really nasty. Once we've had chicken pox or the vaccine, that virus is in our body. And the point to the vaccine is to kind of help our body get used to handling it so that it doesn't have a strong reaction to it. But it lies dormant in our nerve roots, in the spinal cord, and it hangs out there until we're stressed, we get a bad sunburn, we get a bad illness, and then that can cause it to reactivate. Because while it's hanging out dormant in our nervous system, our immune system is holding it at bay. But when our immune system is busy doing something else or knocked down for some other reason, the zoster virus can reactivate. And it will travel along that nerve from the nerve root, and that's why we see it show up in specific patterns. It almost always respects the midline, which means it's going to be on one side or the other. It's very rarely on both sides. But if somebody's had a transplant, or if somebody has had HIV and is on immunosuppressant medications, we can see something called disseminated zoster. And that's really, really a bad thing to have and generally requires hospitalization and intravenous antiviral medications. But typically what we see in the community is these clusters of blisters on a red base. And it's usually limited to one side of the body and then follows these specific patterns we call dermatomes. It generally lasts a few weeks, even if it's not treated. And the virus can be transmitted through the blister fluid. So once it's all crusted, you're not going to give it to somebody. But when it's actively blistered and oozing, you could transmit that virus to like a grandchild or something. So it is important to keep those areas covered up and maybe avoid contact with especially young children who might not be vaccinated yet. These are the dermatomes. It's just a really pretty picture that kind of shows these nerve patterns and how it kind of can show up in parts of a body. One of the things that's a really scary place to get this is on the face, especially if you start to get blisters on the tip of the nose. That can affect the optic nerve and can affect eyesight. So that requires urgent, immediate medical attention. And one of the, so I'll get there. So what you can do, get vaccinated. Vaccines decrease the chances of getting zoster by up to 90%. And it also, if you do get it, it decreases the severity of your outbreak and also decreases your chance of getting something called post-herpetic neuralgia. Post-herpetic neuralgia means pain, nerve pain. And that can be really nasty. The more times you get zoster in the same space, because once you get it, you're likely to get it in the same space if you get it repeated times, and the more times you have it and the older you are when you get it increases your chances for having this post-herpetic neuralgia. And it can be very, very debilitating, and it can be also really, really hard to treat. So another reason why to make sure that you're getting that vaccination. Identifying it early is really important because treatment, the medications that we use, really only shorten the duration of it. It doesn't erase it. They're not erasers. And we want to catch it as early as possible. Once it's kind of been about 72 hours past when you started having the blister show up, chances of the medication helping are much lower. It's still worth taking because it might decrease the risk of that post-herpetic neuralgia, but we really want to catch it early. Usually between 2 and 4 days before the blisters show up, you might have what we call prodrome. So itching or burning or pain in an area that's on one side of the body. Might be it might be dry skin, there's all kinds of other things that might be, but if you start noticing little clusters of blisters show up, then that would be something to pay close attention to. And then to seek medical attention, as I mentioned, the antiviral medications are most effective if it's started within 72 hours of symptoms. The medications help us recover more quickly with less pain and decrease that postherpetic neuralgia. You can also take things like acetaminophen, ibuprofen, calamine lotion, topical anti-itch, topical lidocaine can be helpful in the early stages too. Moving on to the feet. I feel like I don't do this yet, but I keep saying that I'm going to do it, is get gold star stickers for anybody over 60 who doesn't have fungus on their feet, because it's so common. And I often say that the feet are the unsung heroes of the human body. They do so much for us. And there is no such thing as a beautiful foot after the age of 6 months. Once we go upright, it's downhill for the feet. They have a big job to do. And we don't pay much attention to them. Most of us are embarrassed about our feet. We try to cover them up. And people apologize for their feet more than any other body part in my clinic. They're, oh, I'm sorry, my feet look horrible, and I just say, no, we should be celebrating our feet. And they look bad because of all the work they do for us. No other part of the body has to bear the weight of every single other organ. So they don't get very much blood flow too. And as we get older, it gets harder for us to pump blood back up to our heart because we have muscles around our arteries, and the arteries pump away from the heart, and we have just these wimpy little valves. So when the veins kind of get older, these valves get leaky. And once we get fluid down into the lower part of our legs, our calf muscles help bring fluid back up. And then we have these one-way valves that when the fluid goes up, they open up and allow fluid to pass, and then they close down again. Well, as we get older, that gets leakier. And that's one of the things that leads to edema. And if anybody's had bypass surgery or had vein harvesting to kind of take a vein from the leg to put it into the heart, we need our heart a lot more, but that does create more problems. So it's really important to even just do toe raises or think about ways that we can keep fluid moving back up towards our heart. So engaging the calf muscles is one way. Compression stockings is another way. And so with this low blood flow and being so far away from the heart and taking all the pressure of gravity and all the weight of our entire bodies, feet struggle. And fungus is everywhere. It loves wet, moist places, especially swimming pools, gyms. So if you are going to places to work out, which is great for us to do from a social standpoint and from a health standpoint, wear flip-flops or some sort of covering if you're in any sort of public shower. But the fungus spores can live for a long time, even when they're not moist. So we'll pick them up just walking barefoot. And once they get into the nails, they're really hard to get out. Once it's in the nails, it also puts you at risk for getting fungal infections on the feet. And what do we usually do when we get up in the morning to get dressed? We usually take our pajamas off, if we're wearing pajamas, change our underwear. Our underwear go off, new underwear come on. And if we're putting our foot through those underwear, that fungus that's on our feet come right up to here. So that's the most common thing that we can do to prevent jock itch, or tinea cruris is the official name, is to put our socks on first. And especially if we have nail fungus. So what you can do, if you do have nail fungus, keeping your nails trimmed short. Some people use a Dremel tool to kind of keep them so they're not getting so thick. Urea cream is very useful. It's something you can get over the counter, or it can be prescribed to you. It's an acid-based cream that helps. It doesn't treat the fungus, but it helps keep the nails thinner and easier to manage. Once the fungus is there, as I mentioned, it's really hard to treat. There are oral antifungals that you can take. They are hard on the liver. We usually have people on a 3-month course of those, and it takes another 6 to 9 months to know if it worked, because the toenails grow really slowly. Once even if you do clear it, the chances of it coming back within a year are very high. So even if you do clear, you will want to use an antifungal spray, powder, or cream once or twice a week as a preventive measure. If you have nail fungus and you decide it's not worth going on those medications and you're just going to live with it, it's also helpful to treat once or twice a week as a preventive, to prevent it from spreading to other nails or to prevent it from spreading to the feet. Having diabetes increases the chances of this spreading too. So it's something, if you do have diabetes, you want to pay a special attention to your feet. Vicks Vapor Rub is a suppressive. This is easy to find. It's inexpensive. It contains a variety of different essential oils, including menthol. I can't recall off the top of my head all of the ones that are in it, but a number of them do have antifungal properties or fungal suppressive properties. When people do clear clinically with Vicks Vicks Vapor Rub, which means the toenails look clear. Once they stop using the Vicks Vapor Rub, it comes back faster than we expect a new infection. So we think that it's just suppressing it, but it can be useful, and that's kind of a home treatment that you could try. When it's between your toes, keeping your feet dry, there are antifungal powders, there's absorbent powders, that zinc oxide paste. If you do get cracking and scaling in between the toes, usually it's that last space, the fourth interdigital space or the third and fourth on the feet, that zinc oxide paste can go a long way because it's going to dry it out. The bacteria and fungus that are there aren't going to be as happy, and it can be very effective. Using antifungal creams or antifungal sprays or powders, there's a number that come available over the counter. Terbinafine, clotrimazole are the two that are most commonly used, and then, as I mentioned, oral medications. Okay, moving on to skin cancer. 1 in 5 Americans will develop skin cancer by the age of 70. So this group, there's about 35 folks in here, so 7 of you are, by the numbers, going to have skin cancer. Now, we're also a fairly fair-skinned population, and it is more common in people who have fair skin, although people who have dark skin also get skin cancer. So it's not something that if you have darker pigment in your skin, you can just say, oh, I'm not going to get skin cancer, because often it ends up diagnosed late, and it ends up much more advanced when it does happen. So it's important to recognize that. More people are diagnosed with skin cancer each year than all other types of cancer combined. And about 90% of non-melanoma skin cancers, those are the 2 most common types we see, basal cell and squamous cell, are attributed to UV radiation, and that's sun. Melanoma is a little bit different because there's some genetic predisposition to that as well. And when I say sun, I'm also talking about tanning beds. I think all of us, at least me and the rest of you, not my daughter maybe, went through a period of our life where tanning beds were very popular, and we thought it was healthy, and we didn't know how dangerous they were. Now we know the youth are still tanning, so if you have grandchildren, if you have any influence over them at all, and even if you don't, say it, because the more times they hear it, the more chances it is that it's going to sink in. And we're seeing melanoma in 20 and 30-year-olds. It's really sad because it's, once they've got one, they're at risk for getting more. And if you start in your 20s with melanoma, it's, your chances of having more significant serious melanomas later in life are more significant. So this indoor tanning is really a big deal. There are countries in the world that it's completely banned. There are a lot of states that you have to have parental permission for under 16 or under 18, depending on the state, but it's still widespread. Just driving down the Beltline a couple months ago, I saw the LA tan, $20 for a year of unlimited tanning. It's like, well, that's job security for me, but it breaks my heart for the people that are going into these tanning beds. And I was one of them. I burned really easily, and my mom thought it was a good thing that I could go in a tanning bed before our vacations to Jamaica and Mexico, and so I wouldn't burn. And I didn't. But I think I was in there probably about 6 to 12 times over the course of my life, and I'm a walking poster child for melanoma because I also had sun poisoning and blistering sunburns and all of the risks. And it is true that you won't burn as much, but the damage that you get from that strong UVA radiation, it's unregulated. These tanning beds are completely unregulated, and any tan tells us that your skin cells have gotten enough UV radiation damage to want to protect the DNA, and that's what the tan is. That's what that pigment is your cells trying to protect the DNA by making pigment to kind of shield the nucleus, which is where our DNA is kept. So risk factors for skin cancer, indoor tanning and then blistering sunburns, especially in childhood, for melanoma, but any sunburn across a lifetime, the basal and squamous cell is kind of a clock that just keeps ticking. So the in and out of the grocery store, the softball games or the soccer games where there's no shade to be found, that's such a frustrating thing for me because we've got these young kids out there. Hopefully they're wearing some sunscreen, but a lot of kids, especially teenagers, aren't that interested in wearing sunscreen, and they're invincible when they're 20, right? We were. So it's something just to be aware of. Being fair-skinned, having blue eyes, red or blonde hair, that's going to increase your risk. Having a high amount of unprotected UV exposure over a lifetime. Having moles that looked atypical under a microscope. So if you have scary-looking moles and somebody samples them and looks at it under a microscope, if they look normal under the microscope, then that's not a problem. But if they look abnormal under the microscope, that can increase your risk. having had an organ transplant or other conditions that impair your immune system, like HIV, or other medications, having autoimmune diseases where we need to suppress the immune system in order for you to be able to function. That can increase your risk. And then family history, particularly for melanoma. When it comes to non-melanoma skin cancers, the family history plays a role in that we inherit our skin type and we tend to learn sun exposure behaviors from our parents. But there's not a genetic component to those types of skin cancers. So basal cell is the most common one. I see it every single day in my clinic. I biopsy it every single day. It's, over 3.6 million cases are diagnosed each year. They show up as shiny bumps that grow and bleed. Some of them have a central indentation, but not always. They often have a lot of blood vessels, so they have the shiny pink look to them. Now, if you have a pink papule or spot that's been there for 20 years and it's not changing, it's not a basal cell. Skin cancer grows slowly, but it does grow and change over time. One common thing that I hear is I have this spot, it bled, and then it kind of almost healed up, but then it didn't quite, and then it opened up again. So if it heals completely in between, then it's not a skin cancer. But that sort of wanting to heal up but not completely, that is a common thing that I hear about from these basal cells. Squamous cell cancer is the second most common type of skin cancer. We have 1.8 million cases each year, so about half. And they show up as red, scaly, crusted patches or plaques. They can be pigmented, and so they can be very darkly colored as well. They're often tender, painful, and they might bleed. And then melanoma. Melanoma is a serious, serious disease. One person dies from melanoma on average every hour in the U.S. Melanoma is becoming a lot more common. It increased by 27% between the 10-year span from 2013 to 2023. It's much more common in fair-skinned people, but it can happen in anyone. Bob Marley died from melanoma. It was on his foot, and by the time it got noticed, it was very, very advanced. So, and that's the tricky thing when it comes to people who have a little bit more pigment in their skin. It's often much more advanced because people aren't thinking about it. They're maybe not recognizing it. It's different from other moles that you have. So the bad egg or the ugly duckling sign is the biggest thing that I look at. It's something that's changing over time. About 70 to 75% of melanoma shows up as a new mole that continues to change. Only about 25 or 30% is it a mole that's been there for a long time that starts changing. But any mole that starts changing is one that we should be concerned about. And if you see these pictures, none of them really have that stuck-on, waxy, warty look that I talked about with the seborrheic keratoses. We look for the A, B, C, D, E's, but what I will say is the E is the biggest one, changing over time, and then also something that looks really different from everything else that you have. Asymmetry, sometimes we have moles that are not perfect, but if you look at all these pictures, there are lobules growing in all different directions on these pictures. So it's not maybe that it has a notch. That doesn't cause it to be asymmetric necessarily. And a lot of people grow moles that have notches in them. And that's, again, if you're comfortable with the kinds of moles your body makes, then you'll kind of get used to what's normal for you. Atypical border. So border should be about even. Sometimes people make fuzzy borders on their moles, but what we don't want to see these lobules, these kind of like edges that are just really serpentiginous, I guess. They look kind of like a snake moving along. Different colors. 2 different colors is fine as long as they're close to each other in a color spectrum. But once we start seeing reds and blacks or pinks and blacks, then we really start to worry. And then diameter, that basically means nothing to me because some people make big moles and some people make little moles. I've caught melanomas that are, that big on somebody's scalp. I've also caught melanomas that are very, very tiny, almost a pinpoint in size. So it's just, and it was something that showed up new and seemed to be growing quickly, and kind of just wasn't normal for that person. It's hard to say dark is bad because I see people who all of their moles are really dark, and in them it's the pink mole that's going to be the scary one, or the one that's just a lighter color, and it's having that variation in color. And the reason for doing those skin self-checks, again, is know what's normal for you. I could look at anybody's skin in here. I've been doing this for over 20 years at this point, and I can pick out what looks atypical. But you can do that for yourself. You don't have to spend 20 years and 4 years of medical school and 4 years of residency to be able to do that. It just takes the repetition. And that's what I have. I have repetition of looking at all kinds of different patterns over and over again. But you can get that for yourself by just consistently looking at your skin. Don't look at it every week because then you won't pick up on things that are changing slowly. So that's our general recommendations. Once a month is a really good interval. So decreasing risks, we talked about UV protection, avoiding the midday sun between 10 and 4, looking for shade when you can, wearing that UV protective clothing. You look for a UPF of 50 is a good guideline. Sunglasses with wide, large lenses that should say 100% UVA, UVB protection. Appropriate use of sunscreen, SPF of at least 30. Mineral-based is what I recommend to avoid the chemicals, so zinc oxide or titanium dioxide. And then you can even get protective, a lot of the brand new windows will have protective film on them, but you can get that for your car as well. And I had a patient who had a very bad skin disease where she couldn't tolerate any UV on her skin, and she told me it was like $100 to get her car fully UV, the windows UV, with a UV film. So it wasn't as expensive as I thought. Eating a healthy diet, high in plant-based foods that are rich in antioxidants, low in processed foods. That also goes a long way to helping your body fight off skin cancer when it does show up, and also to helping keep your skin looking great. And this is just the monthly skin self-checks using that hand mirror and a wall mirror. Having somebody help if you can, although if we're dependent on somebody else doing it for us, we have to make sure that that person's going to be around a long time. You know, I have people who say, well, my husband looks at my back and he looks at mine, but somebody's going to leave somebody at some point. And unfortunately, that's the way life goes. And so, or somebody's eyesight might go and it just might become more. So it's really good to kind of get that sense for yourself. And if you do have problems with your eyesight, then having people help you with that. Mm-hmm.
I was wondering if there's been a lot more cases of cancer because men are shaving their heads and going bald.
Mm-hmm. I mean, there's a lot of reasons why we're seeing more and more skin cancer. I mean, yes, probably wearing a hat really goes a long way to helping that. So when they are out in the sun, wearing a hat. I'm not a big fan of the baseball caps because, especially if you don't have hair, it leaves the backs of your ears really exposed. I spend part of my time working at the VA, and so I work with a heavily sun-exposed population, folks that spent years in Vietnam and other subtropical places. And you know, if that cap, we see bad skin cancers get down if they start tracking along the cartilage. So if you do not have hair, then I generally recommend a rim, one, you know, a broad brimmed hat. And then, you know, and women, we don't go bald, we go thin, but we don't put sunscreen on the top either. It's hard to get it through the thin hair, and that's a place I do see, you know, skin cancer as we get older and as our hair gets thinner. So think about that, like wearing a hat is going to help protect that part of your scalp too. So we're right at time, and I just have a few more slides, 3. So we'll go through these, and this is the basic skincare tips. Proper bathing, so using lukewarm water, not hot. And I have to say, I love hot showers myself, and it's hard to get away from them, especially in the winter. If you don't have problems with dry skin or eczema or other problems with skin breaking down, then go for it. But just make sure you're moisturizing after. But if you do have eczema or you do have really itchy skin, then the hot water is not your friend. You want to limit your showers to no more, and baths to no more than 10 minutes because water actually causes, especially hot water, causes those blood vessels to dilate, which brings more moisture to the surface. And then when we get out of the bath or shower and dry off, all that moisture goes right to the towel. We want to use gentle cleansers, so non-sudsy, non-antibacterial. Now, if you've had skin cancer and had surgery to have it removed or surgery from other reasons, your doctor might recommend that you use an antibacterial soap, but in general, we don't necessarily, most of us don't need antibacterial soap. There are some conditions where people need an antibacterial soap because they're prone to infections, but in general, we want kind of a gentle, non-sudsy cleanser. Using your hands, not abrasive loofah sponges, which I know feel really good, especially if you're itchy, but we don't really need that. We can get good, clean skin by just using our hands in a gentle way. If we are causing those micro trauma to the skin, like those loofah sponges, that actually creates breaks in the skin barrier and can set you up for more problems. And then the other thing about those scrubby sponges and the loofahs is they tend to be a great place for bacteria to like to live because our bathrooms tend to be, you know, very humid. And so you will, if you are using something like that, you'll want to be changing it or finding a way to wash it frequently. And then heavy moisturizers, creams, ointments, or oils, as I've talked about. UV protection, I think I've kind of gone over this already. And reminding you that sunscreens are imperfect. They are a part of a sun protection plan, but they are not they should not be our first line of defense if we're really wanting to protect ourselves from the visible signs of the aging process and from skin cancer. And this comes from the NIH. And I really love this little cartoon because it talks about tips for healthier skin as you age. And this is a website that you can go to get more information. But staying hydrated and eating a healthy diet, protecting yourself from the sun by protective clothing, sunglasses. They should have a hat on there. That's my only beef with this. Managing your stress, getting regular moderate exercise, especially as we get older, our muscle mass is harder to maintain. So finding ways of getting aerobic exercise and some weight-bearing exercise. Don't smoke. Smoking really accelerates the aging process because we have all these pro-oxidants and carcinogens that are getting directly exposed to our facial skin. Using moisturizer and then checking your skin often. And that is what I have for you all today.
Wow, thank you. Thank you so much. Can you all hear me on this? Can you hear me? Okay. Thank you so much, Apple. Bodemer, I am blown away with this amount of information today. This was fabulous. Thank you so much. So we will have this recording on our website, and we will also have a copy of the presentation slides, too. So if you don't know our website, it's mcfarland.wi.us. It's also on the cover of our newsletter if you need to reference that. This will also be showing on our cable channel. So if you get a chance to see our cable channel or look at the McFarland YouTube channel, it'll be on there as well. But before we wrap up, who has questions? Who has a question for Dr. Bodemer today about skin health?
What is your attitude on pedicures?
I think it's tricky because it's a good place to pick up fungus. Especially, you want to know that the tricky thing about fungal spores they are hard to be sure that you've disinfected from them. And so a lot of times they're washing, they might be using an antiseptic wash to clean the tools that they use for pedicures. But lots and lots of people have nail fungus, and lots of people with nail fungus go to get pedicures so that they don't look quite so bad. So if you, and I'm seeing some nails here that look like there's not much fungus there, you might want to do your own pedicures at home so you don't pick it up.
I've had 3 pedicures in my life.
Yeah.
Usually because it's part of a bridal shower or something,
So that's my feeling about them, is you just really got to be careful with them. There are some people that do pedicures that help take older folks take care of their nails.
Yeah, we do have foot care options.
Yeah.
We recommend a couple of different places that are specific for older adults.
Yeah.
That question right here.
I'm just wondering whether or not mosquito bites do mosquitoes only bite when my body's a certain temperature, or do they bite anytime they can get me?
That's a good question. There's a lot of what do I want to say, of just folklore out there about mosquito bites, or why mosquitoes bite certain people and not others. I am not attractive to mosquitoes. They do not like me. I'm not sweet enough for them, I guess. But I think there is maybe something I've heard, gender differences, that maybe males tend to be bitten more than females. That kind of plays a role. If I'm out hiking with any of my guy friends, I'm usually not getting bit, and they are. I don't know, I haven't studied it, and it's a tricky thing. There's some people that say that diet can make a difference, that mosquitoes are going to be attracted to certain diets. Some people say blood type makes a difference, I don't know how they're detecting blood type, especially because they haven't tasted us by the time they're biting us. But they're attracted to CO2, so they're attracted to what we're breathing out. And I don't really know why some people are more susceptible than others.
I have a quick question on that. So you mentioned butt paste or diaper rash ointment. Would you recommend that instead of calamine lotion for bug bites?
I mean, calamine lotion is going to be drying as well. It's something that you could use. Calamine lotion is going to dry on the bite, whereas any of the diaper paste is going to be a little bit greasier, so you're going to be more prone to potentially staining something with a grease stain, especially if you're with intertrigo. I'll often tell my patients, just beware that you want to have underwear that you don't care about having a grease stain on, because it might do that, or So that is one difference in the two. I think it depends. With spider bites, they tend to blister more for some people. And you'll see little kids, if any of you have grandkids, like mosquito bites tend to be really exuberant in little kids, or they can be, until our immune systems kind of get used to them. And then because actually the bite doesn't cause the redness and itching. The mosquitoes inject saliva into us. They basically inject an anticoagulant into us while they're sucking our blood. And that's what we're having an allergic reaction to. And some people, if you can avoid scratching them, then you don't usually get quite as big of a welt. But once you start scratching them, that kind of spreads the saliva, for better for better explanation, around in the skin, and that creates more inflammation and gets our immune system more revved up.
Have you, is this on? Okay.
Yeah.
Have you ever heard of using Epsom salts for toenail fungus, like to soak your feet in Epsom salt and water?
I haven't seen any evidence of that. I've heard about it a lot. And again, like warts, nail fungus, there's all kinds of things out there because we don't have anything that works super great. I think there is some good data about the Vicks Vapor Rub. I work with a physician assistant at the VA who has her patients soak their feet in vinegar, and she has them like keep a tub, pour the white vinegar in, and they use the same tub for 5 to 7 days, and at the end of the week they toss it and get fresh vinegar. What she's told me is it works, but it can take a year to year and a half of regularly doing that, and that's so standing there for 5 to 10 minutes every day. So I've heard that. The Epsom salts, I can't, like the vinegar I get because the vinegar does have a really significant change in the pH, where the Epsom salts, it doesn't. That's why we tolerate it in a bath. So I think for the Epsom salt to do anything, you would have to have a really concentrated salt solution, and it would probably really irritate your feet. So that's kind of my take on that.
Right here, and then I'll come over to you. Okay?
Just two quick things. The zoster vaccine has, you showed a slide with 90% efficacy, but what about duration on that? I mean, if you get it at 60, does it last at 90% until 90? And
I don't give those vaccines. I don't know if we know exactly how, because that vaccine, even the kids' vaccine wasn't around when I was a kid. So I think we're going to probably learn more as the people who've been getting the vaccine get older. I'm not sure how old that vaccine is. I want to say it's probably 20 years or less, and so if you're 50 when, that's the age where you get it and then you get a booster, we're probably going to be giving people boosters. I do not know the ins and outs of the vaccine world, so I can't give you a clear answer on that.
And the other thing, just quickly, was sometimes you'd like to treat seborrheic keratoses even though they're not harmful.
Yes.
And I've read that there is a prescription of high-dose hydrogen peroxide that you can do. That doesn't sound that sounds like it could be harmful.
Yeah, I have not seen that. That's not something that I'm aware that can be prescribed. There's a lot of things out there. One of the most dangerous things that I see is black salve, which some people will use to treat skin cancers, and it's a terrible, terrible idea. I've seen it promoted by some alternative providers as an option, and it's not one that I would recommend at all. And I have seen people want to use that to treat the seborrheic keratosis. It can cause really bad ulcers and bad scars in the skin. I have had some patients that have had luck with the wart freeze away. So this is ethylene chloride. It doesn't get cold enough to treat a wart. So I get really mad about it when people are like, oh, I tried treating my wart at home with the wart freeze away. I'm like, well, of course it didn't work, because it would never work. It's not nearly as cold as the sprays that we use in the clinic, but it can help thin out some of these seborrheic keratoses, and I've had a number of patients who've been really happy with it. I've also had some who said it didn't do enough. I think it works better for the thinner keratoses, and if you do have a really thick one that you're wanting to try to navigate at home, you would just need multiple treatments. That usually is around $15 to $20. There's a lot of different brands out there. Some you break, like one of those glow sticks, and then it has a little like Q-tip type applicator that you'd put on, and others are I've seen some that are even a spray bottle, and some are paint on. Salicylic acid is a wart treatment, and that might work for some of the thin ones. It's there's a lot of things out there, a lot of different botanicals that are promoted, and I go on Amazon and I've seen those too, and a lot of people are very excited and say, I found something and it's going to work, and then usually a couple months later they're very disappointed. So I think the wart freeze away from an over-the-counter is the best thing that I found. And then removal typically is cosmetic. So if you come in to see, some primary care doctors do the freezing and some don't, but dermatologists almost always have access to that. If it's in an area that's frequently got friction and they're inflamed, bleeding, painful, then insurance typically does cover that. But if it's kind of the middle of your chest and it really is cosmetic, then they're not covered, and you would have to check with your doctor's office because there's always cosmetic fees, and it ranges. I know what we charge at UW, but I don't know what other people charge outside of our system. Yeah. Question right here. Oh, yeah.
Comment. I just wanted to say that I use a combination of Epsom salt and vinegar together,
Okay.
and it took a lot longer than a year and a half, but it's been successful.
Oh, good.
And then one other thought that I was told too is that if you choose to go have a pedicure in a salon, take your own polish, because they're using brushes from people.
And I think I'd be more concerned about the tools that they're using, but you're right. Yeah.
Because they've been doing other people's toes
Yeah.
with that bottom of nail polish.
Yeah. Yeah, that's
I
true.
saw Kathy up here. Speaking of nail polish, let's reference our model again.
She just happens to be wearing sandals, and I could see her feet.
I like to wear sandals in the summer.
Yeah.
Cool. Now, my question is the difference between eczema and seborrheic keratosis.
Okay.
Because I think both of them are kind of like scaly patches. They can both be kind of itchy. So how do you?
Yeah, so they're actually, so eczema is a issue where your skin barrier isn't very strong. There's a protein that helps keep the skin held together that is deficient in people who have eczema. It's usually kind of a combination of a genetic predisposition and then some sort of environmental trigger that will kind of get your skin revved up. It is a situation where the immune system is kind of over-exaggerated in that area, along with all the other pieces that go with eczema, so it's kind of a multifactorial condition. It's usually red patches, and it'll show up. They're not very discrete, meaning it's not usually like a single circle that's small. Seborrheic keratosis, and so you can have red seborrheic keratoses, but they tend to be smaller. Seborrheic keratoses can get itchy, but eczema is almost always itchy, and eczema is more diffuse. So that's the difference. And eczema should never be brown or dark, and it shouldn't really raise up. It might be a little bit swollen, especially if it's really inflamed and you've really been scratching, but you shouldn't really see that kind of raised warty surface to it.
Regarding seeing your doctor or a dermatologist, full body skin exam, do you recommend that at all? I mean, you're talking about self-exam.
Yeah, I do not unless you have risk factors, or if you or your primary care doctor has identified a spot of concern. Then a lot of people come to us through their primary care doctor, and they'll say this person's got a new spot that's been bleeding, and then we'll send us a picture, and then that helps us kind of triage them. and sometimes they'll say this person has a strong family history of melanoma, has never had a skin check, then that might be a reason to come in. But if you don't have a family history and there's nothing in particular that's concerning, most people don't necessarily need annual checks.
Thank you.
Well, thank you everyone for coming today. Let's give Dr. Bodemer one more round of applause. And a couple of just housekeeping items. Make sure if you didn't get an item when you came in, grab one of those on the way out. Again, thank you to a new med spa and Lakeview Modern Dentistry for those donations. And if you are not on our mailing list, there is a place for you to sign up to receive our newsletter on a monthly basis. Thank you so much for coming.